the aftermath of the horrific events that occurred on 9/11, followed by the anthrax attacks, it became glaringly evident that our country lacked health care preparedness. The need for better collaboration and coordination by hospitals, long-term care facilities, emergency medical services, and public health was recognized in lessons learned by involved communities. Our community was no different. Planning efforts in our region were underway prior to 2001. However, the events that occurred on September 11th changed everything. How would healthcare institutions, public health, and first responders coordinate their efforts for a unified response in future events? How could we ensure we were prepared? It was through federal funding directed toward answering these questions that healthcare coalitions were born. Soon after the attacks, Homeland Security Presidential Directives 5 and 8 were signed. These were the forces that caused the creation of the new United States Department of Homeland Security and called for the development of the National Response Plan. These directives also provided the framework for all organizations, including those in the private sector, to develop planning and response standards. It was then that hospitals became eligible for significant emergency management grant funds. Prior to 9/11, most hospitals lacked structured disaster plans and were inadequately prepared to respond to large-scale events. They were unable to handle the surge of patients after a mass casualty event or to continue operations after losing power, leading to preventable losses. These experiences emphasized the importance of hospitals in disaster response and prompted President Bush to develop the Hospital Preparedness Program, or HPP, in 2002. In 2006, Hurricanes Katrina and Rita provided one of the first tests of healthcare preparedness after 9/11. Following these events, several reports identified major gaps between preparedness and actual response capabilities. Hospitals lacked sufficient preparation for coordinating with outside agencies, experienced numerous communication problems, and lacked the ability to accommodate alternate standards of care. In 2008, the National Response Framework replaced the National Response Plan, providing guidance for all levels of domestic response partners to prepare for disasters and emergencies. By providing a unified national response, engaging all agencies in partnerships, and by using a tiered and flexible response plan, we became better equipped to respond more efficiently and recover more quickly. In addition to aligning with the National Response Framework, healthcare organizations began to see changes in emergency management. These changes highlighted the importance of maintaining patient care services and safety during any hazardous event. The Hospital Preparedness Program, HPP, evolved under the new Office of the Assistant Secretary for Preparedness and Response, ASPAR, requiring even greater alignment with other response agencies through joint patient surge, mass fatalities, and evacuation planning. Coalitions continued to build better relationships, demonstrating incremental but continuous improvement. This was evidenced by their involvement in joint exercises and regional resource sharing using national standards. Timely and efficient emergency response is critical to enabling the nation's hospitals to react to a worst-case scenario. The elements of the next big disaster are unpredictable. Its scope is unknown. What is clear, however, is that when something does happen, it will be too late to plan and prepare to protect facilities, assets, and people. Healthcare facilities, including hospitals and long-term care facilities, must commit time and resources to get ready before the next time. Hospital Preparedness Planning, HPP, has advanced the preparedness of hospitals and communities in numerous ways. This includes taking an all-hazards planning approach, increasing surge capacity, tracking the availability of beds and other resources using electronic systems, and developing communication systems that are redundant and interoperable with other response partners. Moving forward, HPP must be responsive to lessons learned and be flexible in meeting community needs. One way this will occur is by building and strengthening healthcare coalitions like the Eastern Virginia Healthcare Coalition, EVHC. The EVHC is comprised of healthcare entities, local health districts, long-term care facilities, dialysis centers, and other tertiary facilities, as well as emergency medical services organizations. The Eastern Virginia Healthcare Coalition is our geographically inclusive body open to all organizations that provide or support health services within the 26 jurisdictions that wish to work collaboratively on emergency preparedness, mitigation, response, and recovery activities. Our healthcare entities have primary responsibility for triaging, admitting, and providing definitive medical care for patients affected by disasters, even providing decontamination if needed. In addition, they are also responsible for continuing to provide basic health care services to the community, such as routine emergency care not related to the disaster, delivering babies, and treating acute illnesses. The coalition partners must be able to surge when needed and sustain operations in the event of a longer than anticipated crisis. Whether the emergency results from natural events or unintentional disasters such as power failures, plane accidents, or events involving radiological, biological, and chemical contaminants, or from terrorist attacks involving chemical, biological, radiological, nuclear, or explosive agents, adequate preparation by healthcare organizations is critical to safeguarding the lives of more than 1.8 million residents and workers who call Eastern Virginia home. In the wake of a large-scale disaster, the healthcare entities of Eastern Virginia cannot manage the surge of patients independently. The EVHC accomplishes its goals and objectives by building relationships and partners, strengthening community medical resiliency, surge capacity, and capabilities, developing emergency preparedness, mitigation, response, and recovery capability guidelines, facilitating communication, information, and resource sharing, maximizing utilization of existing resources, coordinating training drills and exercises, guiding and supporting the function of the Regional Health Care Coordinating Center, RHCC. The RHCC concept exists in all 50 states under different names. Its primary tool is a program known as the Virginia Healthcare Alerting and Reporting System, EVHC. EVHC is a secure, web-based emergency management system to coordinate and streamline individual and regional healthcare response to all hazards. Fully interoperable, built-in modules handshake with one another to save time, reduce confusion, and provide intelligent real-time responses. EVHC utilizes WebEOC for crisis and incident management. WebEOC is integrated within the application, so members do not have to log on to WebEOC separately. WebEOC is updated every time an organization edits his organization and assigns users, or a user updates his or her account information. The RHCC is activated to effectively coordinate the distribution of resources in response to an event requiring assistance and/or mutual aid. All levels of government utilize emergency operations centers to manage a mutual aid response, but they are not responsible for the private sector. The RHCC is a multi-agency coordination center. It does not command or direct, it coordinates. Membership in the EVHC includes core members, acute care hospitals, and partner organizations and entities such as long-term care facilities, medical clinics, and district public health departments. Additionally, there is an executive council with an elected chair and vice chair to conduct coalition business as directed by the membership. A staff exists to conduct day-to-day operations directed by the membership and executive council. Currently, this core staff includes a regional healthcare preparedness coordinator, a mitigation and recovery coordinator, a long-term care preparedness coordinator, a communication specialist, an inventory management specialist, a RHCC manager. The EVHC strives to provide necessary commodities to diverse and often competitive healthcare organizations with differing priorities and objectives who work together through collaboration to ensure that each member has the necessary medical equipment and supplies, real-time information, communications systems, trained healthcare personnel. The EVHC has also been tasked with coordinating the development of a regional supply cache, equipment standardization, and the development and implementation of a regional disaster training and education program. As a nation, we are not only resilient, but also innovative, committed, and dedicated to protecting the things we cherish. After the 9/11 attacks and over the past 15 years, that trend has never lapsed. Whether it's hunting down those who intend to harm us, building new levees, or preparing for hurricanes and wildfires, we will continue to mitigate, plan, and practice. We are always improving. We are thankful that healthcare has become an indispensable partner in these endeavors.